Okay, so good afternoon. Today I'll be talking about the lung cancer, especially stage 3, where the imaging usually ends and MDT judgment actually begins. It's the most challenging stages of all the lung cancers. I'm Dr. Sandeep Sapkota, MCS second year resident from BPK MCS. And these are my objectives. I'll be talking about key interpretation of the CT features, applying a structured diagnostic approach to diagnose, differentiating operable, borderline operable, and inoperable stage 3 lung cancer. And basically, the complete run through of CA lung will be given as a not a surgeon's perspective, but how oncosurgeons would think a cancer. So these are the backgrounds which we already know. We all know that lung cancer is the most common non-melanomatous malignancy in the world, with the most common being small cell type that accounts for 70 to 80%, and then the small cell type which accounts for around 15%. So this is the Globocan data of 2022. We are still relying on the same data. Rhetorically, we should be getting new data around 25-26, but I could not find that in the new sites. This is from the national scenario. The national scenario reflects exactly same to the international scenario. The lung cancer is the most common in both sexes combined as well as in males. So now reflecting back to our topic, this is the key slide the data obtained from the preliminary series, which represents, it's a Kaplan-Meier curve, which represents the events in different stages according to the node negative and then node positive. This first graph is a clinical node positive graph, and then second graph is a pathological node positive graph. So the one thing that is common in this both graph is the event is increased, that is mortality is increased as the number of nodes or clinical nodes are increased. So if the pathological nodes is high, that is N2 disease, then the mortality or events are likely to occur earlier, which shows that the lymph node metastasis or locally advancement of the disease is one of the most important predictor of the overall survival in case of lung cancer. This is the basic anatomy. I will be skipping this for the time constraint. And also the bronchopulmonary segment. These are the basics for the operability of the cancer. So these are the pathogenesis of the squamous type and adenocarcinoma are different. When we talk about the surgery, when we talk about operability, we are usually talking about the non-small cell lung cancer, because small cell lung cancer are primarily not a surgical disease. It is primarily treated by chemotherapy or chemoradiation. So these are for the operable cancers like squamous and adeno, basically non-small cell cancers. And this is for the squamous type, where you can see the myriads of epigenetic changes from loss of heterozygosity to telomerase dysregulation till TP53 inactivation and the establishment of the invasive carcinoma. So this is the adenocarcinoma. Similar pathogenesis, where the most common one thing we have to take care in mind is the adenomatous, atypical adenomatous hyperplasia, which will change into bronchoalveolar carcinoma of lipidic pattern and then into invasive carcinoma. Usually the solid pulmonary nodules that are around 8 to 9 millimeter, they are termed to have AAH, which will later progress into the invasive adenocarcinoma. So now the solid pulmonary nodule of bigger sizes are advised to operate. So this is the basic clinical manifestation of the lung cancer. Some manifestations are from the tumor itself, some are from the regional spread of the tumor, some are from the metastatic, and there can be paraneoplastic syndrome as well. I will not be diving in detail into this. And these are the basic diagnostic process. The chest X-ray is, even though the most commonly frequently done investigation, but it gives the very little information if the disease is very small. And then the bronchoscopy to determine the location or to obtain the biopsy, and then the other modalities which we will explore later on. And then the most important one, which gives the maximum yield in our diagnostic approach, is the CT scan, which helps us to identify the lesion, identify the local advancement of the lesion, nodes, as well as the distant metastasis as well. And then PET scan, which is definite to stage the disease for the identification of the nodes, and extrathoracic meds as well. and other laboratory analysis, mediastinoscopy, and full mediastinal staging, as well as BATs, either for diagnostic or any interventional purpose, can also be used as a diagnostic algorithm. So this is the diagnostic approach. The figure basically talks about the same thing that I have said: chest X-ray, then CT. If it is normal, then we don't need to undergo any further interventional procedure. But if there is a mass, then bronchoscopy, and for a suspected lesion, we have to send for the histopathological investigation. So now the diagnosis is not just about the confirming cancer, because we have to quantify between the least invasive diagnostic approach first, with the highest stage site first. The most accessible site which gives the adequate tissue should be chosen, rather than the site which gives the quick tissue, and the diagnosis and staging should be simultaneous. And after obtaining the biopsy, establishment of the histology and tissue preservation for molecular testing, accurate mediastinum staging and unnecessary procedures are to be avoided. So in case of the lung carcinoma, we should never biopsy the lung mass first if we suspect the mediastinal nodes are enlarged, or if we suspect these are malignant, because the staging is the most crucial component of the lung cancer treatment. It is the crux of the lung cancer treatment approach, which we will discuss in the next slide. Now there is the paradigm shift. We are not just confining ourselves to the non-small cell or small cell carcinoma, or for the squamous and adenocarcinoma. We are definitely going towards the molecular testing and standard of care, where most of in our scenario, around 30% of them interpret the EGFR mutation, and even in around 4% squamous histology, the EGFR mutation can be seen, which is further sent for the targeted cancer treatment. So after these all review, I'll be talking about the bronchoscopy, and the bronchoscopy is a very useful investigation, yet it has a limitation. It cannot be used in a tumor with the peripheral ridge. If the tumor lie within the 2 centimeter, the bronchoscopy use is very limited, and then diagnostic yield is also very questionable. Sometimes the sample may be too small, and then there are technical obstacles like patients coughing. We usually don't do it in sedation. We just do it in the local anesthesia. So the excessive mucus or blinding can obscure the visualization, and there are procedural risks. So in this video also, we can see there is a huge tumor in the right main bronchus, obstructing the right upper lobe. So this is the easy tumor to obtain the tissue from. So again, the guided decision: if there is a peripheral lesion, CT guided biopsy is most commonly used, and if there is central lesion, bronchoscopy is done. In central lesion also, we have to see the lung field. If the tumor is invading the bronchus, then bronchoscopy has some role, but if it is not invading the bronchus, then we should definitely send the patient for CT guided true cut biopsy. And then if there is a suspicious mediastinal node, the complete mediastinal staging using the EBUS and EVS should be done. And if the patient presents with a pleural effusion, then thoracentesis followed by VATS biopsy, pleural biopsy should be done. So this is the guided decision for diagnostic approach. So if we talk about the CT scan, the first image that we see in any CT diagram is this localizer image. This is the localizer image that is available even in our film as well as diagram. If there is a huge mass like this, it helps us to guide the exact site of the treatment so that we can look further in the same site. After that, this is the mediastinal staging. I'll play the video of this diagram file. This is the mediastinal staging, and from that localizer, we know that there is a huge mass in right upper lobe, and we can see the huge mass with the changing density. in this non-contrast film, and then some nodes are also there in this. Some nodes are also there in this non-contrast film, which will further confirm using the contrast enhanced film. This is the long window of the same patient, and the long window is basically it helps us to define the exact site or lobe of the lesion. So this is the fissure that we can see. This is the major fissure. Also here we can see the major fissure. That means the tumor is basically in the upper lobe and some invasion to the lower lobe as well. So that's how the long window helps us to define the exact site of the tumor. And then it also helps in segmentation of the lung by tracing the bronchus as well as arteries. The enhanced portion in the lung window are all arteries. This can also be used for the segmentation. So these combining the long window and then mediastinal. So this is the long window in MPR 3D segmentation. MPR imaging in the axial, sagittal, and coronal image, which helps to give exact 3D interpretation of where the lesion is, if it is resectable or not, how much is the extent of the disease, and if there is any nodes, and it also helps in the exact fissurization or segmentation of the lung. And finally, after knowing the lesion, so you can see this is the necrotic lesion here, you can see, and then enhancement is seen with the neovascularization or neoangiogenesis at the tumor site. So here we can see, so this is the innominate vein that will further drain. This is the SVC. This is the pulmonary artery. This is SVC. This is ascending aorta, and this is the descending aorta. The bronchus has been divided. I am just showing the two main important nodes that are very essential in the lung cancer. One is this node, that is 4R. This node up to this extent, that is up to the left of the trachea, are all 4R. So if it is enlarged, it is the mediastinal node enlargement, and the patient should be, full staging should be done. First one is this, and then second most common is the one after the division of the bronchus, that is tissue around here, the subcarinal nodes, or station 7, which I'll discuss in the next slide. This is the most important nodes in lung cancer, the 4R and the 7, because these are the most commonly metastasized nodes. In some countries, the screening LDCT has also been prescribed, especially in China, and the probability of finding the benign looking tumor along with the AHA and then suspicious lesion or solid pulmonary lesion with the ground glass opacity around, that can be obtained in early stage. That is, disease can be checked in early stage in those cases, and this is the guideline. The one takeaway from this figure is, if there is any solid pulmonary nodule which is greater than 9 mm, either we can take the patient to surgery or we can just observe 3 monthly. If it is lesser than 9 mm, then 6 monthly observation is adequate. So that's the key takeaway from here. 9 mm is the cutoff for solid pulmonary nodule. So even the small solid pulmonary nodule that is sub-centimetric, in high-risk patient like smoker or extreme of ages, we can do the segmentectomy of this particular site. This is the 3D segmentation that I did from one patient at our hospital. So we can use the softwares like 3D Mimics or Slicer, and then we can know where the tumor is from lower lobe, fissure, and then outer aspect and then upper aspect, and we can localize the tumor intraoperatively, because we cannot put the fiducials in our center. So this is what we have to rely on for operating. So yeah, we can do the lung preservation surgery while taking out the solid pulmonary nodules as well in this way. So starting with the basics run through of the staging. This is from the 9th AJCC book. We are now following the 9th AJCC classification for the lung cancer. The T1A tumor, T1 is basically 1 to 3 centimeter, where T1A, B, and for the C is divided. And in T1 also there is the superficial spreading tumor of any size that is just limited to the bronchus is also T1. So this is one catch. And if the tumor is even less than 3 centimeter, but there is the endobronchial extension and there is the collapse of distal segment, then it is T2. That we have to keep in mind. So now T2, 3 to 4 centimeter, less than 4 centimeter. Now, as I said, any size of tumor with distal collapse of the segment, then it is a T2 tumor. And then T3, it involves the structure that can be resected. So this AJCC, they usually took 3 decades to confirm all the TNM staging in 1970s before they came out with the first iteration. So T3 are basically the lesion which are usually resectable after downsizing or either upfront. So these are tumor with 5 to 7 centimeter diameter, or tumor with the invasion to the azygos or phrenic nerve. We can just ligate or excise the azygos vein without any difficulty, and we can also sacrifice the phrenic nerve of one side. There will be just flapping of the diaphragm. We can pligate it, and then tumor with rib extension can also be removed with the 3 segments of the ribs without any reconstruction. And if it has invaded to the parietal pleura, it can also be taken out with stripping of the pleura around the tumor. So these are very much resectable tumor. And if there are satellite nodules around the tumor in the same lobe, it is also a resectable tumor. Basically, after downstaging of the tumor, which I'll talk in the coming slides. So T4 are the only one tumor that is resectable is the tumor that involves the carina. Because we can resect the carina and mobilize it up to the 5 centimeter down by different releasing maneuvers. So T4, only one tumor that involves the carina is resectable. The rest of the tumor that is more than 7 centimeter, one which invades the SPC or aorta or other heart structure or mediastinum, thymus. So these are usually unresectable. So this is the nodal site chart as per the 9th edition. As I said, 14, 13 and 12 are all within the one lobe. These are the N1 nodes, and then 10 is a hilar node that can be found in the junction of one upper lobe bronchus and lower lobe bronchus. These are the 10 nodes, and 9 is along the pulmonary ligament, 8 is along the esophagus, and 7 is the most important node in the lung cancer. It is the subcarinal node, and then 4 are or 4 is the paratracheal node. 3 is the around the 3A and 3P, it is further divided. 3 is around the great vessels, that is SVC. And then 2 is upper mediastinal or below the clavicle, and 1 is above the clavicle. So the 1 is usually a N3 disease. All 2, 4, 3, 7, these are N2 disease if it is involved in ipsilateral side. If it is involved in contralateral side, then it is again the N2 disease. So shortly, if there is a segmental nodes, then these are all, if it remains within the lung parenchyma, then these are N1 nodes. If it goes out of the lung parenchyma to the mediastinum, they are N2A nodes, and 2 nodes. N2 is further now divided in 9th edition as N2A and 2B. This is because the 2A has better prognosis than 2B, and 2A can be taken for the upfront surgery, whereas 2B should be taken for the surgery only after the chemotherapy or neoadjuvant therapy. And then N3 is any above the clavicle, and then contralateral mediastinum. One thing we have to take care, we have to know is the lymphatic flow of the lung, that is from, if we look at from the lung parenchyma, that is 14, 13 and 12 nodes, it usually goes to the 10, and then it usually goes to the 7, and then 4, and then 2, and then 1. So this is the lymphatic flow of the lung, basically lymphatic flow of the lung. The one exception can be the upper lobe tumor can drain directly into the four. In a similar fashion, the left-sided upper lobe tumor can directly drain into the 5 or 6 nodes. So upper lobe tumors have poorer prognosis or may have early recurrence because of the skip meds that is mentioned in the literature. So this is the M1 staging that has been classified further M1A, B, and C1 and C2 in 9th staging. M1A is the primary tumor with pleural effusion, malignant pleural effusion. M1B is the single extrathoracic metastasis. M1B, and then M1B, it can also include the involvement of a single distant non-regional lymph nodes as well. C1 is multiple metastatic in one organ, that is either brain or liver, and C2 is disseminated metastasis all over the body. So these further division in 9th edition is because of the prognosis of the different stages, and even in M1B with only one meds, if the this tumor is, if resectable, it is advised to resect, or if not, we can do the resection of the primary surgery and then ablate, can ablate the metastatic site as well. So the concept of the oligoprogression or oligometastatic disease in the lung cancer is evolving. So this is the T staging. We are mainly dealing about the stage 3. So stage T1, in T1 it is further divided into 1A1, 2, 3 now, and it is all because the prognosis is different as per the different cases. And also the new recommendation is, if there is a tumor with T1C with the EGFR positive mutation, the question comes if we should give the adjuvant TKI or not. And the current recommendation is we can generally avoid or can just observe the T1A and T1B, that is A1 and A2. But if there is a high risk feature present, then we should definitely give the adjuvant from 1A3. Whereas Audura trial has started its osimertinib from stage 1B onwards. So this is the catch as per the Chinese evidences. And then we have 1B, which is T2 lesion, and 2A, which are usually T2 lesion, advanced T2 lesion, and 2B are either early T lesion with N1 disease or advanced primary lesion, and 3A covers the multiple stages from the early lesion with N2B involvement to the advanced lesion without the nodes, that is T4. As I said, the T4 more than 4 cm, which involves the corona, is only one lesion that we can operate, rest all are inoperable. We can do the surgery or we can venture the surgery only after downstaging the tumor. Whereas the upfront surgery, there is no head-to-head comparison between upfront surgery and neoadjuvant treatment in these early, that is 1A, 1B, 2A disease. If there is a nodal involvement, then systemic control using the chemotherapy is definitely the good decision, or should be decided as per the MDT. So there are still the controversies in the staging, that is tumor size cutoff. The authors have now demonstrated the prognostic value size of more than 5 centimeter and recommended that it should be incorporated in T3 disease. So this is one, and then T3 N0M0 disease is lumped into the stage 2B, whereas prognosis of the patient with the chest wall invasion is very poor as compared to the other T3. So there is also this controversy, which may be changed in the coming iteration as the evidences are coming up. And then the normal lymphatic drainage of the lung doesn't always the midline, as I said. The right-sided lymphatics might drain into the left order of the trachea across the midline, and the survival of the patient with level 3 and 7 nodal involvement is markedly poorer. So this is also another thing that we that is very controversial. So after all this, the exact use of mediastinal staging is to properly stage the disease if it is a stage 3 or stage 2. Suppose if there is a suspicious node in CT, the recommendation is the PET CT scan, but PET CT scan cannot always be done, especially in the financial resource constraint setting like ours. So we may have to rely on the CT alone, or we can do the complete mediastinal staging using the EBUS and EUS. So it is highly sensitive. The station combined EBUS and EUS, because all single EBUS or single EUS is not or never complete, because there are some stages that are left by EBUS and then EUS. The EBUS generally cannot go beyond the carina, so 6, 7, 8, 9 they are all left out by EBUS, and EUS it can access the 6, 7, 8, 9, so it gives the complete mediastinal lymph node mapping. So this is also the same lymph node mapping. This slide was an old slide while I was presenting on the EUS. I hope it's not necessary now. And then we have the ASTER trial, which shows that the recommendation, earlier recommendation was the mediastinoscopy before commencing the surgery, and the ASTER trial shows that the EBUS plus EUS is superior to mediastinoscopy, or comparable without doing the mediastinoscopy is very invasive procedure, whereas EUS and EBUS are least invasive procedure. It's just like the endoscopy. So the least invasive procedure is equivalent to the mediastinoscopy as per the ASTER trial. So complete lymph node dissection using the mediastinoscopy is not necessary. So we can see the mediastinoscopy is done this way, like in a thyroidectomy is done, similar fashion, same position, but we take the scope beneath the great vessels along the pretracheal fascia. So there is a chance of great vessel injury. It has happened in our case as well. We have to open the sternotomy or do the sternotomy, open the chest to just to ligate the vessel. It is a invasive and one prognosis with a grave complication. So we should not always do the mediastinoscopy as earlier advised. In stage 3, or if it is a suspicious stage 3 or 2B disease, it was advised to do the mediastinoscopy sampling before the commencing the surgery, but now EBUS plus EUS alone is efficient. So these are some trials showing the in surgery EBUS plus EUS after then surgery and then doing the systematic nodal dissection can just waive the mediastinoscopy as of. So this is also another evidence showing that the mediastinoscopy is not generally necessary as shown in a guideline. So then our treatment is side by side very much influenced by the pathology according to histologic subtype, IHC conformation, PD-L1 types, because the recent Caspian trial, then Keynote and Checkmate trial in the lung cancer is also showing quite improvement in the overall survival after the use of immunotherapy. Also there are evidences coming for the use of immunotherapy in neoadjuvant as well, combining with the chemotherapy. So these are the common diagnostic mistakes. As we have finished the diagnostic approach and we are now entering into the treatment, we have to take care in mind that biopsying the lung mass before assessing the nodes is very much unethical in case of the lung cancer. We are directly interfering with the prognosis of the patient, and then inadequate tissue for NGS is of course a financial burden to the patient, and then assuming PET positive nodes are malignant is also another mistake, because in our case tuberculosis, another infectious pathology, is very common, which can affect the uptake of the PET nodes, mediastinal node. And then skipping the mediastinal staging while just venturing the surgery is also a common mistake that we will do in the treatment. And then starting treatment before the complete staging should never be done in a lung cancer, especially in a 2025 where the evidences are showing marked improvement in overall survival, even though it is not a curable cancer. So basically stage 1 and 2 are early stage, and they are taken up for surgery very early. And stage 2A, 2B, these are where the debate happens. And stage 2A, they are usually, now there is a stage 2A, 2B, 3A, 3B and 3C as well. And stage 3A are usually one which can be operated after the downsizing the tumor. Whereas stage 3B is now in debate, and stage 3C are now definitely taken for the definitive chemoradiation. And stage 4 are the metastatic disease, either done the palliative care or palliative chemo or just best supportive care at home. So as been described, the stage 1 and 2 principles, surgery is the standard of the care. It's a treatment of choice. So if it is medically inoperable, then stereotactic ablative radiotherapy can be done in a medically inoperable case. Basically, local ablation is the treatment of care. The discussion comes in the use of adjuvant after the stage 1A. So as I said, stage 1A, the adjuvant can be waived because, so this stage 1A, if it is margin negative, it can just be observed. Stage 1B, if it is margin negative, we can just observe. And stage 2A, we can either observe or adjuvant systemic therapy is given. Stage 2B, adjuvant systemic therapy is to be given. And stage 3A, even after the complete resection of the tumor, adjuvant systemic therapy is most essential. The guideline has also recommended the sequential chemotherapy and RT to be considered. However, it is not practiced after the ablation, after the surgery. But we can, if one site we have to give the radiation, then it may be the mediastinal node that has been taken out during surgery. Other than that, there is no lesion if the R0 is already performed. So I think the adjuvant systemic therapy is adequate, and it is shown in many evidences that just adjuvant systemic therapy in stage 3A, 3B is adequate after the surgery, whereas stage 3C are usually not ventured for the surgery. So this is again, we'll discuss this in coming slides. So neoadjuvant chemotherapy followed by surgery versus upfront surgery in non-metastatic non-small cell carcinoma. It is a 2017 systematic review from Chinese authors. It's a systematic review and meta-analysis of different RCTs. So we can the enrollment in this trial were all the cases from stage 2B. So stage 1A and 2A were not included in the trial. So the overall survival had significantly improved in the group who received the neoadjuvant treatment. So and the disease-free survival is also significantly better. Also, we can see the mortality outcomes is better. The recurrence and metastasis is significantly better in groups with neoadjuvant chemotherapy. There is no postoperative complications as well, and the chance of pathological complete resection is also there, is also better. Here you can see. So the stage 2B onwards, it is always advisable to commence the surgery only after the neoadjuvant chemotherapy. This is the key takeaway, that is, it definitely improves the disease-free survival, reduce the total mortality and recurrence and distant mets, and increase the RG resection as well. In stage 2B to 3A, 3B, the stage 3C and 2A are not also included in this one. So adjuvant stage 1 is not routine. As I said, TKI may be considered in highly selected patient, tumor more than 3 cm, but still stage 1A, 1A3, as I discussed. Poorly differentiated histology, we should also look for the biology of the tumor, and then viscera involvement or lymphovascular invasion, and then STAS positive, that is spread through airway space, that is most frequent. There is a chance of recurrence. So if there is a driver mutation, we should it is always better to start patient with the targeted therapy for 1 year. So this is what we do before the surgery. We first do the FEV1 or spirometry, and FEV1 is calculated. If it is questionable, then DLCO is done, whereas the guideline says the DLCO should be done in every case before the lobectomy or any pulmonary resection. So if the DLCO is very low, or if it is questionable, then we do the cardiac exercise test, where we calculate the VO2 max. And if it is more than 15 ml per kg, then only we can do the surgery. If it is less, it is medically inoperable and can be taken for the RT for local ablation. So these are the lung cancer surgery, and all of these type of surgery we have been performed routinely in our center. The wedge resection, usually for METs or primary lesion. Lobectomy, it is the most commonly done procedure. There is always a debate between the lobectomy and the lesser pulmonary resection like segmentectomy, but it has been the proven standard of care since the 1990s, and it is most commonly done procedure. Then pneumonectomy for the central tumors, they are less commonly done nowadays unless there is a destroyed tumor or trapped lung because of the central tumor. These are usually due to the big lesions and usually taken up for the chemoradiation. And then we can also do the sleeve lobectomy, that is taking the cuff of the bronchus tissue and then re-anastomosing it with the carina. So this is the sleeve resection. It can be done for the central or small hilar tumor of the So after the complete resection of the tumor and the free resection margin is proved microscopically, lobe specific mediastinal nodal dissection with complete hilar and intrapulmonary nodal dissection should be done intraoperatively. This guideline is for centers who have frozen section. We can avoid, if in frozen section the segment 7 is negative, we can avoid dissecting the nodes above that. But in our center, where the frozen section is not available, we try to dissect every nodes that is accessible, the mediastinal node that are accessible. So at least 6 nodes should have been removed, with 3 from the mediastinal node. This is the, and then it will be known as the complete resection. Lesser than that, there is a high risk of systemic occult mets. We should always consider for the adjuvant treatment, and there should be no extracapsular extension in the nodes. And the highest mediastinal node should always be microscopically free. If it is microscopically positive or involved, then adjuvant treatment should be definitely preferred. And another question is what type of surgery to be commenced, either minimal at optimal versus extensive and aggressive. The decision is very much changed now. We always opt for the minimal and optimal surgery. VATS is the standard of care now, with the preservation of the lung parenchyma. That is, we can just take out the segment of the lung now. We should not take the whole of the lobe, but segment of the lung now. But there is still a debate if the segmentectomy is better than lobectomy. The Japanese series has shown the increased local resection in segmentectomy. So this is a paper for sublobar resection. Authors around the Europe, they don't support the sublobar resection, that is segmentectomy, whereas only Japanese or Chinese trials are very much in favor of the sublobar resection. Then there is open versus minimal invasive surgery, that is VATS and RATS. RATS is out of the concern as of now because it is not available. And VATS is most commonly done with the lesser complications, so it is the standard of care as of now. So if we see why we should talk about the stage 3 lung cancer, it is because of the challenges in stage 3. The heterogeneity in tumor, stage migration, that is 3A, 3B, 3C are interchangeably migrated, and clinical trials of another era may not be applicable to today's stage 3. And then advances in treatment, and then the modalities as well, they all complicate our management choice in stage 3. So there is heterogeneity in biology, there is heterogeneity in tumor location and treatment plan, there is heterogeneity in individual patient risk profile and interinstitution diversity along with the ability to perform the complex surgery in different surgeries, so different stages. So stage 3 in one institution may be inoperable, whereas stage 3 in another institution are operable, so these are very heterogeneous. And the data are not homogeneous because of the diversity among the surgeon. So there are myriads of paper that evidences, this is all from the 2025 and 25 that you can get in the literature, and there is no definitive approach to stage 3A and 3B, whereas stage 3C are definitely taken for the chemoradiation, and stage 3A and 3B, if 3B should be taken for the definitive chemoradiation or can be operated, it all has a diverse evidences. So basically, 3A, T1 to 3 lesion with N2 or T3 N1 lesion, they can, this is the indication as per the South Asian evidence literature from the Tata Memorial, and so this can be opted for the surgery. After that, it is always better to abort the surgery or prefer the other modalities. So these are CT lesion with the peripheral lesion. There is no encasement of the artery. This is very much easily resectable disease. Some cases like this with extension to the ribs or chest wall, these are also resectable. And these kind of picture at a periphery with a stellate lesion, these are also resectable. There is no involvement of the great vessels. These solid lesions, and these are the lesions which have, this is left-sided lesion which have involved the left interlobar artery or left pulmonary artery, branch of the left pulmonary artery. So this kind of resection can only be done after the downsizing of the tumor. And then some which have involved the aorta or descending aorta or the SPC with SPC syndrome, they should be taken for the definitive chemoradiation. So then, as I talked about the lymph node dissection, lymph node, all the accessible nodes should be dissected. The recommendation is up to 10 we are already taking out as with the lung. 7 should be dissected and should be sent for the frozen section. If it is negative, the guideline says that 4 can be avoided. So we can see the 4 can be avoided. If it is positive, then 4 hours should be taken out, 2 hours should be taken out, and 3 should be taken out. If 1 hour generally not taken out, if it is positive preoperatively, then this is the N3 disease. So now sometimes there can be incidental N2, especially in centers like ours where we don't do the PET CT in all cases. There can be incidental N2. So if the tumor is completely resected, the adjuvant platinum-based CT should be given, and if the N2, for the N2 we can also consider RT for the nodal station. Or if there is an incomplete resection, then definitely the CT followed by RT or concurrent CT followed by sequential RT is to be given. Or definitive chemoradiation can also be considered. So 5-year survival as per the stage is very variable, and the lesser resection results in higher recurrence rate and reduced survival as per the evidences as of now. And survival in stage 3 is very dependable if we do the staging properly and commence the treatment properly. So potentially resectable, induction chemo RT followed by surgery. If it is unresectable, then definitive chemo RT is the indication. So the recent consensus is the management of oligometastatic non-small cell lung cancer, where the one organ, if there is 1 to 3 metastasis in brain, adrenal or bone, then we can still treat the patients with the intent of curation. That is, it is no more just a palliative intention, but curative intention can be added to these oligometastatic disease. So this is the approach that I have talked about. I'll skip this because we have already discussed about this. And if the stage 4 are always taken for palliative or best operative care or hospice care. If it is operable and medically fit, then they are always resected. If it is operable, still medically unfit, then RT. If it is inoperable or borderline operable, then downsizing after chemoradiation, then surgery are to be done. And if it is definitely inoperable, even after the neoadjuvant, then we should also always send for the definitive chemo RT. So this is not all for the stage 3 lung CA. This is just a very basic and just the tip of an iceberg. the patient doesn't come simply with the guideline picture. There can be synchronous tumor which has to be discussed as per the tumor. There can be metachronous tumor. So this is for the basic idea that I have tried, and I opportunity. Also, this is our YouTube channel, which I regularly regularly upload the video.
So video subscribe गर्ने
हजुर
subscribe and like video.
यो स्टेज 3 जुन छ लङ क्यान्सर, यो त स्टेज 3 त हामीले टिएनएमले गरेर भन्यो। लोकेसन त जुन लोकेसनमै हुन सक्यो। ट्युमरको लोकेसन जस्तो सेन्ट्रल, पेरिफेरल अथवा अप्पर लोब, लोअर लोब, हाइलर, क्याराइनल, जहाँ पनि लोकेसन हुन सक्छ। लोकेसन वाइजले सर्जरी र प्रोग्नोसिसमा के फरक पार्छ?
लोकेसन वाइजले प्रोग्नोसिसमा पार्छ। एक त अप्पर लोबको अलिकति प्रोग्नोसिस पुअर छ बिकज इट ह्याड प्रोपेन्सिटी टु ह्याभ स्किपमेट्स, पहिलो कुरा। अर्को कुरा चाहिँ सेन्ट्रल ट्युमर्स आर डिम्ड इनअपरेबल, बेसिकली दे आर भेरी इनअपरेबल एट प्रेजेन्टेसन, स्पेसली इन आवर सेन्टर्स। पेरिफेरल प्रोग्नोसिस सिरिजहरूमा पनि अप टु 65% स्टेज 3 मा 60% जुन सर्भाइभल आइरहेको छ त्यो पनि मलाई लाग्छ पेरिफेरल ट्युमर्सकै नै होला। ओन्ली ट्युमर्स वी हेभ टच द कराइना, टिफो लिजन। टिफोमा चाहिँ कराइना छोछ भने इट इज अपरेबल। अजाइगस भेन अपरेबल त्यो T3 मै पर्छ, तर एसेन्डिङ अर्टा, डिसेन्डिङ अर्टा, त्यसपछि एसबिसी अनि फ्रेनिक नर्भ, बाइलेटरल फ्रेनिक नर्भ, दिज आर अल इनअपरेबल। हामीले लिम्फ नोड निकाल्दाखेरि जस्तै मानिलियो लेट्स सपोज हामीले त्यति गर्दा गर्दै हाम्रो अराउन्ड 6 नै भइसक्यो। एटलिस्ट 6 त रेकमेन्डेड हो। 6 यदि कुनै पनि ओटीको एचपीको रिपोर्टमा 6 आएन भने एडजुभेन्ट। हजुर 3टा स्टेसन देन 6 नोड्स, 3टा मिडियास्टिनल नोड स्टेसन। हजुर त्यो T1 स्टेज 1A ए हजुर किमो मैले एडजुभेन्ट होइन, किमो होइन, मैले जस्तै इजिएफआर पोजिटिभ ट्युमर स्टेज 1A3 मा 1A1 र 1A2 मा त अब्जर्भ मात्रै गर्न सक्यो। 1A3 मा इजिएफआर पोजिटिभ केस छ भने स्मोकर हो, यङ पेसेन्ट हो, पोटेन्सियल्ली लङ्गर लाइफ छ, यङ पेसेन्ट हो, एसोसिएटेड विथ अदर ट्युमर्स पनि पहिला हिस्ट्री थियो भने यस्तो केसमा चाहिँ 1 इयरको ओसिमोटो।
नर्मली हामीले चाहिँ टिकेआई इजिएफआर पोजिटिभमा चाहिँ 1B भन्दा
हजुर अडुरा ट्रायल, हजुर अडुरा ट्रायलले चाहिँ 1B बाट स्टार्ट गराएको थियो। हजुर सर हामीले मिडियास्टिनल म्यापिङ चाहिँ खास बेसिकली एज पर गाइडलाइन पेट सिटी अर आइदर पेट सिटी अर इयुएस इबस गर्नुपर्ने हो। पेट सिटी फाइनेन्सियली अभाइलेबल छैन। हाम्रो मिडियास्टिनल म्यापिङ इज सोल्ली डिपेन्डिङ अन सिटी। डायगम फिल्म आफैले हेरेर मिडियास्टिनल इफ कन्ट्राल्याटरल लिम्फ नोड चाहिँ सस्पिसियस छ भने देन इबस युएस गरिन्छ। ए सिटी स्क्यानमा चाहिँ यस्तो छ, सिटी स्क्यानमा जस्तै नोड यत्रो देखियो लार्जेस्ट डायमिटर, देन त्यसको पर्पेन्डिकुलरली एउटा सर्ट एक्सिस हुन्छ। त्यो सर्ट एक्सिस डायमिटर सुड इफ इट इज मोर देन 10 mm देन इट इज सस्पिसियस साइज वाइज चाहिँ। साइज वाइज हजुर त्यो साइज चाहिँ एकदमै यो अपरेटर डिपेन्डेन्ट हुन्छ सर। अब उहाँहरूले 1.5 निकाल्नु भएको, मैले नापे भने 2 सेन्टिमिटर पनि आइन्छ। 0.5 चाहिँ मार्जिन हुन्छ। अनदर थिङ द्याट वी क्यान लुक इज हाइलम, जुम गरेर फ्याटी हाइलम छ कि नेक्रोटिक हाइलम छ। इन्हान्समेन्ट अफ द नोड्स, अघि यहाँ इन्हान्सिङ नोड्स आइरहेको थियो, त्यो डेफिनेटली मेटास्ट्याटिक नोड भयो।
धेरै केस हेर्दै गएपछि एक्सपिरियन्सले त्यसलाई बताउन जान्यो क्या। ठ्याक्क उसले कति सेन्टिमिटर भनेको थियो त्यही सेन्टिमिटर हुन नि सक्छ, नहुन नि सक्छ, होइन उसले अन्डर साइज गरेको पनि हुनसक्छ, ओभर साइज गरेको पनि हुनसक्छ।
मैले चाहिँ हजुर एउटा नयाँ सिस्टम छ सर, नोड ऱ्याट्स भन्ने। जस्तै बाइऱ्याट्स जस्तै पाइऱ्याट्स, लाइऱ्याट्स जस्तै नोड ऱ्याट्स एउटा रिपोर्टिङ डाटा सिस्टम छ। त्यसमा चाहिँ एउटा साइज, अर्को चाहिँ कन्फिगरेसनमा चाहिँ हेटेरोजेनिटी अनि कन्टोरिङ त्यसपछि गएर फ्याटी हाइलम अफ द स्ट्रक्चर, यो सबै हेरेर स्कोरिङ गराएको छ कि सर। मैले पनि एउटा स्टडी गरिरहेको छु इसोफेगसमा, यो चाहिँ नोड ऱ्याट्स हेरेर इसोफेगसमा नोड पत्ता लगाएर माथिको हामीले सिटीबाटै नोड पत्ता लगायो भने किन डिसेक्ट गर्ने त गर्नै पर्दैन भन्ने टाइपको एउटा क्वेसन, रिसर्च क्वेसनले एउटा स्टडी गरिरहेको छु। त्यो एउटा नोड ऱ्याट्स भन्ने टुल चाहिँ क्यान बी बेनिफिसियल। हजुर
फुल पेसेन्टलाई अब पिएफटी एउटा एकदम मोस्ट इम्पोर्टेन्ट हो। दोस्रो कुरो चाहिँ लिम्फ नोड म्यापिङ, जस्तै अब आयो साइज इन्टरमिडिएट साइज आयो होइन, वी आर नट सेफ, कि त हामी फलोअपमा राख्नु परिरहेको छ।
हजुर
6 महिनापछि आउनु बढेछ भने हामी त्यसपछि यसलाई इभ्यालुएसन गरौँ भन्ने होइन। सो वाइ टु वेट फर द्याट 3 months इफ वी आर हाइली सस्पिसियस होइन। अनि एभ्री केसेसलाई हामीले चाहिँ मेडियास्टिनल म्यापिङ गर्छ कि गर्दैनौँ होइन, जहाँ सस्पेक्टेड छ त्यसलाई पहिला हामीले गरेर जस्तै भन्यो सब कारण निकालेर यदि त्यो नेगेटिभ छ भने अरूलाई हामीले गर्नु पर्दैन होइन। यदि त्यो पोजिटिभ छ भने हामी कन्ट्रोलले हेर्न पऱ्यो।
हजुर
भन्नु खोजेको हामी सबैमा गर्छौँ कि युजली रिसेक्सन गर्ने बेला मात्रै गर्छौँ।
युजली रिसेक्सन गर्ने बेलामा जस्तै कन्ट्राल्याटरल त सबैमा गर्दैनौँ सर हामीले। मिडियास्टिनल स्टेजिङ एकदमै ल्याकिङ छ। इट सुड बी डन इजले हो त मिडियास्टिनलको। अहिले त इबस एस्टर ट्रायल अनुसार चाहिँ इबस युएसको छ सर, इबस छ, युएस पनि छ। हजुर हजुर छ सर। हामीले कहिलेकाहीँ चाहिँ एकदम मिल्छ सर, मिल्छ सर एकदम बल्की। जस्तो हजुरले भन्नुभएको थियो पेसेन्ट लेफ्टमा सुतिरहेछ, बल्की स्टेसन 7 निकाल्यौँ, स्टेसन 4 नि बल्की होला। कन्ट्राल्याटरल छैन भने त ग्यारेन्टी नै भएन। कन्ट्राल्याटरल त हामी पुग्नै सक्दैन हो। त्यस्तो हामीलाई प्रि अपरेटिभ शङ्का लाग्यो भने हामीले इबस युएस गर्छौँ। पार्छ सर।
स्टेजमा कस्तो हुन्छ भने हामीले ट्रेनिङले यतातिर T3 देख्यो, अब N1 हो कि N2 हो कि N3 भनेर कन्फ्युजन चाहिँ धेरै भयो। अनि किनभने त्यसले गर्दा हाम्रो ट्रिटमेन्ट पनि डिसाइड हुन्छ, प्रोग्नोसिस पनि त्यसैले गर्दा दिन्छ। त्यही भएर यो गर्न पाएको भए अझ राम्रो हुन्थ्यो होइन।
हजुर के सोध्नु?
त्यो रेडियोलोजीबाट आउँदाखेरिको रिपोर्ट
N2A अब N2A मा चाहिँ सब करेन्ट चाहिँ निकाल्छ। N2